All right. Okay. Today, what you're going to have a look at is traumatic conditions of the chest, right? So what I say was, we all learn about chest X-rays. I know you guys want to learn about, in other words, the consolidation, what's the lung abscess, what's this, what's that of congestion, and we'll get to that later on. But I just want to finish off with trauma first, which won't take too long, and then we'll kind of get into all of this as well, right? Because that actually takes a bit of time to understand. You have to understand the pathology of disease. You have to understand why it looks like that on the X-ray, and then it becomes easier to understand. But trauma is just trauma. That's it, right? So yeah, let's have a look and see. So the first thing is the sternum, all right? So the good part is your sternum is not going to fracture everything. Most of these are things that you'll see like once or twice a year. But the problem is if you miss it, it has the potential to have serious consequences. All right. So where is your sternum? Right there. Okay, your breastbone, basically. All right. But the question is, what's behind that? Lungs. Yeah. What else? Heart. Very good. Anything else? Major blood vessels, trachea, things like that. So in other words, there's a reason why you have such a hard bone right here at the front. It's to protect everything that's there underneath, right? So in other words, a fracture of the sternum tells you that there's something that could possibly go wrong behind it as well, right? The fracture in itself is nothing major. You're never going to die from a sternal fracture, but it's what could be injured behind the sternum that's the problem, right? So generally what happens is a direct force directed from anterior to posterior, so a direct hit on the chest, right? Be it a steering wheel, a punch, a heavy object, wherever it may be, something hits you directly from the front. Now, like I say, the heart is just behind it, so the possibility of heart damage, heart contusions, even lung contusions, rib fractures, all of that is possible, right? So whenever you see a sternal fracture, always do an ECG, always take enzymes, right? Because the cardiac damage is extremely likely, right? And then the ribs and clavicle are also attached to the sternum, right? So the clavicles are attached here, and the sternoclavicular joint, and then the ribs are attached in the sternocostal joints along that side, all right? So these may also fracture or dislocate, okay? Have you guys done CPR with us anytime? Okay, so through your career, when you're doing CPR, sometimes you'll be doing CPR and you just hear a pop, right? That pop is actually the rib dislocating from the sternum because we're pushing on the sternum so hard. So, that's where you can actually see it, if I can put it that way, physically. And of course, the lungs may also be injured, but these generally happen more if the rib is fractured. In other words, if you get a rib fracture with a sternal fracture, that's generally where you tend to see it, all right? So let's have a look at the sternum. Okay, so the question is, I put the question, can you see the fracture? But you should be able to because there's a big arrow pointing at it, okay? So here's the sternum, all right? There we go. Now, we're not going to get into the anatomy of the sternum because nobody remembers it. But here you can see there's an actual fracture over here, right? So that's your heart shadow, right? Running just behind there. So that shows you just the amount of potential that there is for heart injury, for cardiac injury, all right? So cardiac injury can then manifest in a few ways, right? Number one is, of course, direct damage to the myocardium, which is like an ischemic type damage, right? Contusions, which are bruisings of the myocardium. Then you get pericardial tears, pericardial bruising, and of course, just pericardial effusions because there's direct swelling and things like that, okay? So this is what they call a mildly posterior displaced fracture of the sternal body. Okay, so you can see it over there, all right? Now, you do have something called sternal views, which allow you to look at the sternum a bit more closely. This is not particularly a sternal view, but you can see it quite well, okay, on the lateral, okay? Right, let's have a look at another one. So this is a CT of the fracture, okay? So, all right, this is, so there you can see the upper part of the sternum, and here you can see the fracture much more clearly, all right? So this here is a retrosternal hematoma. Okay, so that's what comes behind the sternum, all right? And there you can see again all the other important structures that run just behind it. Okay, all right. So that's why it's so important to be able to recognize it. So let's look at a few here, all right? So here we're looking more specifically at the sternum, all right? So here you see the top part of the sternum. Here you see the body. Can you see the fracture there? All right, so it's quite easy to make out, okay? So that's the fracture there. Now this is a heavily displaced fracture, all right? So you can see it's illustrated here so that you can make it out a lot more easily there, all right? But just so that you know what to look for, okay? And here as well, there is a little fracture over there. But it's more of a posterior displacement than anything else, right? So that's when the entire body is pushed backwards rather than just a fracture. The way that you make that out is that you see the ribs running anteriorly now because they kind of separated from the sternum itself, right? So the sternum is basically pushed back and the ribs got left at the front. Okay, so kind of like an open rib cage, if I can put it that way. So these are the types of things that you have to worry about. And like I say, it's the cardiac problem that's actually the worst. Okay. So sternoclavicular joint dislocation, right? So if you want to know where's the sternoclavicular joint, just follow your clavicle down, and where you feel it, just be where this notch is here. So there's next to that is your sternoclavicular joint, all right? So the best way to know that something is happening there is to feel the area physically, touch the patient and see. So if it's anterior dislocation, in other words, the SCJ is pushed outwards, no problem. That's absolutely fine. We just do a normal sedation, they do a reduction, and that's about it. The problem is if it's displaced posterior, so in other words, pushed backwards, what's lying behind this here that you can think of? Very good. So you have basically major vessels. All right. So whichever ones, be it the on the left-hand side, your aortic arch and its branches, your carotids on this side, because it depends slightly inferior, anterior, and superior, inferior, things like that. Right. So that's where the problem comes. Trachea as well, depending. All right. So there's quite a few things that can happen. Right. And generally, if it's less than 25 years, it's regarded as a Salter-Harris fracture. We're not going to stress about that too much, but just so that you guys understand, I'm going to discuss Salter-Harris a bit later on, so that you guys know what we're talking about. So there you can see the X-ray. So if you compare the two clavicles, right, you can see that this clavicle attaches quite nicely to the sternum, even though you can't really see a sternum that well on the AP view. But here you can see the sternum is being pushed right out. Okay, so like I say, anterior, no problem. Posterior, that's where the problem comes about. So we're going to have a look at what a posterior dislocation is and why it's such a problem. Okay. Let's get it. Okay, so there you can see the clavicle and the sternum. Right. So that's the SCJ that they're pointing to now. So those are huge ligaments, right? So that's a posterior dislocation, right? So there they're showing you the structures that are underlying. Trachea, esophagus, veins, lateral. So right subclavian, right brachiocephalic, left common carotid. So there's so many that can be. So look at all the structures that are being compressed. Okay, so it's not a minor thing. Okay, so there we see the presentation: left upper extremity swelling. All right, DVT on the left arm swelling. All right. So there they're showing it to you again. All right, what it looks like on a CT. Okay. Look at the clavicles again. There you can see. All right. That's just showing it from a CT point. Look at that. With backup from the cardiac surgeon. All right. So it just shows you how important it is that you know about it. All right. And the reason why I mentioned it is that yesterday, if I asked you what to do with the posterior SCJ, you say, no, refer to orthopedics. And then today you'll be like, oh, hold on. Let's get this patient for CT and let's see what's going on, because it's obviously something dangerous. All right. So this is why anatomy is such an important thing to remember. Even if you can't remember every branch of everything, but just as long as you remember your major structures, even if you're not 100% sure of what's going on, you can always kind of guess and say, all right, listen, there's something going on here. So to give you an example, if a patient has a humeral fracture that's displaced that way, not much of an issue. But if they got a displacement this way with a sharp point, your brachial artery, your what you call it, basilic vein, your what you call it, brachial, all are running on that side, right? So you know that there's a possibility that there may be compression. or there may be injury. You're going to check your pulse. So it just as an example, I mean, again, gunshot on the lateral thigh, no problem. Gunshot on the medial thigh, oh my God, So even if you can just remember that part, it will be okay, So don't stress. Okay. Now, as you can see, this was 3 days later. So it doesn't mean that if you got an SCJ dislocation posteriorly, you book a bed in ICU. No. It just means you've got to do a CT to see how bad it is to prevent further complications later. All right. So what are the problems that are generally associated with these types of dislocations is pain, even with the sternum, all right? The chest, it can't move, all right? And the patient can't breathe. With the sternal fractures now that we're talking about, okay? So anytime your rib cage moves, so whether it be a rib fracture, costovertebral dislocation, sternocostal, sternal fractures, you can imagine, you've got to breathe how many times a minute? 10 to 15, right? So what happens is that when there's a fracture, your pain is not actually from the bone. Your pain is from the periosteum, all right? That little covering over the bone. So that's exquisitely sensitive to pain. That's why fractures are so painful, right? So that's got to keep on moving. So what the patient does is this. They use their diaphragm to breathe, right? And if you try and breathe with your diaphragm now, after 2 minutes, you're going to be tired. Not only are you going to be tired, you're not going to be breathing effectively, all right? So that's why they get atelectasis, lung collapse, all right? So the most important thing is analgesia. Get the pain down so the patient can start breathing, all right? And then, like I said, look at the heart, mediastinum, thoracic aorta, lungs, and spine. Look for injuries here because those carry a high mortality, okay? So that's what you've got to look at with sternal fractures, all right? So this was something we saw earlier as well, which was the retrosternal hematoma, right? Now here they are pointing it out, but I must be honest, it's extremely difficult to see on X-ray. But if you are lucky enough to see it, great. I've never seen one, to be dead honest. I've seen a few sternal fractures, but never a retrosternal hematoma, okay, except on CT and things like that, right? But what the retrosternal hematoma is telling you is that there's further compression on the underlying structures. That's why you've got to be worried about it, okay? So even though there's no particular fracture that you can make out here, but there must be a break somewhere so that you've got this leakage of blood, okay? Right. So scapulothoracic dislocation. Pray you never see it one of these, right? But so your scapula is attached, right, by various muscles and ligaments to the thoracic cage, right? So this is what they're talking about is the scapula basically becoming dislocated from everything, right? So what it is, it's the equivalent of an amputation of your upper arm, but internally. So your upper arm is no longer connected to the rest of the body, right? So let me ask you, what's running through this area? You guys should all know this plexus because you'll have to sit and study it for anatomy, and you have to know all the nerves, the roots, the roots, the branches, and the, what's it called? What's that plexus called? The brachial plexus, isn't it? So everybody hates the brachial plexus because how they criss and cross and all of that, and we can never remember it. We learn it for the exams, and then we forget about it, all right? And then you've got your subclavian artery, subclavian vein that then pass into the hand, which become your brachial artery and things like that. So look at this, all right? You've got this shoulder that's basically, or this entire scapula that's moved completely away. So it's putting all of those structures under strain, all right? Basically stretching them out internally. So that's why it's so important to assess the neurovascular status if you do see one of these, all right? The reason being because it's not attached, it's just free floating. All of those structures are being pulled along with it, right? So there's a possibility for it to, rip those structures apart or stretch them to such a point that they no longer, there's no longer blood flow, there's no longer neurological, the neurology is not intact and things like that. So that's why you have to be so careful, right? And the way that you can make it out, number one, it's extremely painful, right? The best way to assess the scapula is actually to get the patient to do like sort of a bench press motion, all right? When you do the bench press motion, it's your scapula that actually stabilizes everything. So if your scapula is not connected properly, it will just move away. Your patient, first of all, won't be able to do it. And when they try and do the motion and compare the two scapulas to one another, you can easily see the difference, right? So that's the thing too. Now, luckily, this is not a common injury. In fact, it's extremely rare. So don't stress. You don't have to go and learn this tonight and watch it on every X-ray, but it's just something to keep at the back of your mind, all right? And with these patients, they need an urgent CT. The reason why I put it was more so that you understand the anatomy behind what I'm saying is whenever you look at anything, consider, is there a possibility of a major anatomical structure being injured, right? So for example, a fracture of your little finger, no problem. You don't have to worry, okay? But fracture, for example, on the medial malleolus of the elbow, where you've got your ulnar nerve and things like that, you've got to immediately start thinking, should I be worried about this structure? Right? So that's the reason that I'm going to do. And if you think anatomically, you'll always do well. Right? So this is something else that we sometimes see, which is diaphragmatic herniation and or rupture. Right? So we've got our two diaphragms, our hemidiaphragms, right? The right and the left. So what happens is on occasion, be it due to trauma, hiatal hernias, whatever it may be, structures from the abdomen move into the thorax, all right? The reason being, your abdomen is generally under quite constant pressure, whereas the pressure in your chest tends to change. Every time you breathe in and out, you're actually changing the pressures within it. So when you have a hole between two structures, if anything increases the pressure within the abdomen or decreases the pressure in the lung to a great extent, pressure will just cause things to move. Okay, have you guys been in surgery already? Okay, when you go for surgery, you're gonna do laparotomies, right? Just basically to look in the abdomen. And one thing you'll notice is when we open the abdomen, everything's kind of comes out, right? Because that's high pressure and outside is low pressure. So everything just kind of flops out. Okay, it's very easy to move things. And for example, the bowel, the stomach, and all, they're actually very slippery things. You know, they can just move around. So when you have any damage to the diaphragm, basically everything from inside can move up. Okay, so what happens is that, and the symptoms are generally non-specific. Patient just has a bit of abdominal pain, sometimes a bit of a cough, shortness of breath, malaise, fatigue, just those types of things. So it's only on X-ray that you may pick it up, or if you're very clever and you listen over that area and you hear the gastric noises, you may suspect it. But to be dead honest, you could say, but I'm close to the stomach, maybe I'm just hearing the stomach in its normal place, right? So here, for example, the gastric bubble should be here. Agreed. Can you see it there? So that's the gastric bubble sitting in the chest. It's not supposed to be there. Okay. So generally, the left side is the more common. The right-hand side is not as common because you've got the liver there. So it's much harder for things to penetrate through the liver and through the diaphragm. But on the left-hand side, you just got the stomach, the spleen on the one side, some bowel. So it's quite easy for things to actually move through, right? The thing is, it can be easily confused with the hemothorax, you know, and things like that. So we've had many cases of people putting IC drains in, and suddenly you get gastric fluid. You don't get blood. So if you ever put in an IC drain and you see fluid coming out, just be able to work on it. Just think, okay, something could have happened. Now, we had a young lady here, I think it was about 3 years ago, who presented to us 4 or 5 or 6 years after a stab to the abdomen. All right. She was stabbed in the abdomen. She had a laparotomy done. Everything was fine at that stage, sent home. 5 years later, she was, in a very mild MVA, nothing serious at all. In fact, to the point that she actually stayed at home. The car just bumped another car. She went forward and hit the dashboard a bit to her tummy, or there was something there and it hit her tummy. She went home and she comes back to us now 3 days later. And she's complaining of pain. She's not okay. So we said, all right, listen, she has had a previous laparotomy. This was an MVA, maybe it's a small pop on the bowel, something like that. So we sent her for X-rays to see what's going on. And that's when this comes back, right? And when I say something, this is not her picture, but when I say this, I mean this particular type of picture came through. When they took her to theater, they found literally a 0.5 centimeter hole in the diaphragm. That's it. It was just 0.5 centimeter in the posterior crux, and everything had just passed through there over the previous 3 days. So as she was getting more pain, she was pressing down on her tummy, she wasn't breathing too well. So it just changed the pressure dynamics, and things just started moving through that little opening, right? And she had a good outcome. It wasn't a problem. But even when we did this, we then did a CT. And when we did the CT, you could easily see all of this gastric content, all of these abdominal contents lying in the thorax. So it's not something you should be checking for every patient, but it does happen. Okay, it really does happen. So you have to be careful. So these are CT scans of the patient. All right. So now we're looking basically within so remember when you look at a CT, we're looking from the bottom. So imagine you're looking through the toes of the patient. So this is the right side, this is the left side, the bottom of the heart. So here we can see, it's just a progressive. You can see now once we're in the chest, you can start to see the stomach, for example. Here's an anterior view. So there as well, you can see the bowel and the, stomach that's moved through the hernia. That's the hernia there. Okay. That's the diaphragm at least, and that's the hernia that's passing through, all right? So splenic and liver injury is very common with this, all right? Sometimes you can get it from insertion of intercostal drains. So what happens is that if you insert your intercostal drain too low, you can easily pass through the diaphragm and pass into the abdomen, even if you don't hit the big structures, but that tends to happen. So then you can actually cause a hernia. If you, I'm not sure, did you guys do dissections in when you guys were studying? Did you all dissect bodies? You did dissect cadavers. I'm not sure if you paid attention to the diaphragm. The diaphragm is actually not a very strong structure, relatively speaking. It's a relatively flimsy structure, because it has to be quite pliable to enable the lungs to go up and down, right? So it can be very delayed if the presentation is small, and sudden rupture if intra-abdominal pressure increases. So in other words, you can have a diaphragmatic rupture. It actually repairs to a certain extent. Then a patient gets punched or kicked, or is MVA like our patient, and that sudden increase in pressure just causes the thing to boom, just explode, right? And it has to go to the, it can't be repaired in any other way, right? Very good. So last one, pneumomediastinum, all right? So basically what we're talking about is A in the mediastinum. Now, the first thing I want you to notice when you look at this X-ray, can you notice the pectoralis muscles? Can you see the latissimus dorsi, the serratus? You can actually see it, right? So this person is not a big bodybuilder. This is actually A, subsurgical emphysema, all right? So that's the first thing that you notice, all right? There's a lot of A in the tissues. The second thing is this patient does have a pneumothorax on this side, but the most important thing, if you look here, this is actually A in the mediastinum. Okay, in fact, getting into the pericardium as well, right? Basically, if you see this is not something you'll see every year. That's how, it's not that common. But you may see it like once in a while. And if you see it, it means something is leaking. When we say something, we mean an air-containing structure. So a bronchus, a trachea, things like that, right? It doesn't only occur in trauma, it can occur in COPD and asthma. But then generally what happens is the leakage is from there and it tracks backwards. Okay, whereas if it's a central injury, it tracks forward like that, right? So they have surgical emphysema of the neck. That's one of the more common things. Because it's in the mediastinum, it tends to cause surgical emphysema in the neck, right? And it helps to differentiate it from a medial pneumothorax. Medial pneumothoraces are not that common anyway, all right? So if you get something like this, something big is broken. That's what I'm saying. It's not just about inserting an ICD and sending the patient to a ward. This patient needs CT. They often need what you call it bronchoscopy. They need operative repair by a cardiothoracic surgeon and things like that. So it's not something to take lightly. That's why I put it. Okay. Now, this is, like I said, something you'll see once in a blue moon. I recall seeing one. That's it. In my entire 20 years of life, I've seen one. That was it. And I didn't even do much of it. I was just standing in the background. Oh, that's it. Oh, okay. And I turned around because it was somebody else's problem. Right. I remember it very distinctly. But what I'm saying is it's not something that you will see that often. But it's if you were to see this and you didn't know what it is, you'd be like, geez, man, what's going on? Yeah. NAD, go home. You know what I mean? It goes on like that. So just keep an eye on it. Okay. Right. So this is just another example of pneumomediastinum. So this is showing just, again, leakage underneath there, right? That's what they're pointing out. So this is also into the pericardium, pneumopericardium, pneumomediastinum, and this is what it looks like on CT. Okay, so generally these are tracheal injuries, right? So just so that you know what it looks like. So we're coming to the end now, right? Aortic disruption. So whenever the aorta is damaged, it starts to leak into the mediastinum. So let's look at a normal mediastinum. Let's just go back to a relatively normal mediastinum. Okay, that's not a good one. Okay, let's go back a little bit, sorry. So this is a normal mediastinum, all right? So you can see it's actually not a very big structure, relatively speaking, all right? It's generally quite thin. It sits behind the trachea and it's not much wider than the trachea, all right? I don't want to give you exact measurements because then it's actually going to waste time because this is more of a visual and an eyeball thing that you do. Now have a look at this mediastinum. Can you see that? Can you see that structure that I'm outlining now? Compare it to the one that you saw before that was just here. So this is what we call a widening mediastinum, right? So once that happens, now there's no A inside here, right? So the only other thing that can leak to such a big extent is the aorta, right? Have you guys seen the aorta? It's huge. It's a hose pipe. Literally, it's a hose pipe. So if your hose pipe is leaking, it's going to leak quite excessively. So these patients are at great risk of exsanguination. And exsanguination means bleeding to death within a few minutes. All right. So most patients with traumatic aortic injuries die before they can receive care. That's just the truth. All right. In fact, up to 90% of them in one study died. All right. So these patients need CT urgently. All right. Now, in this particular one, they're also talking about contusion of the right lung, but that we'll get to. If you see this, you don't do anything besides get a CT. The reason being the CT will look at what the aorta looks like, and this patient needs to be rushed off to, well, if you've got a good general surgeon, they can do it. Otherwise, needs to go to a cardiothoracic surgeon. Right? So these patients will present with signs of hypovolemic shock, low BPs, high heart rates, things like that. Right? The worst thing you can do for this patient is push their BP up. Right? As soon as you push their BP up, you're just going to make them bleed more. All right. So as a general rule in trauma, don't let your systolic go above 100. So if you keep it at 100, that's fine. Once you go over 100, 110, 120, whatever clots this patient has are just being popped out, and you're just causing bleeding to occur. All right. So remember that. Okay. Okay, this is just another example. So here we can see the widening, and we can even see the trachea being deviated over there, right? And here you can see massive, massive mediastinal widening, right? Now, I mean, of course, if a patient comes like this with a history of cough, smoking for 20 years, has not been involved in any trauma, there are other differentials that you can think about. But if this was a traumatic injury, the first thing that will come into your mind, aortic disruption, okay? Okay, and that's the end of it, okay? So what we're going to do next week is we're going to carry on talking about trauma, okay? And hopefully, then we'll finish off trauma in a few months' time. Then we'll get back to normal chest All right. Now, there's a lot to learn in trauma. And what I mean is at university, generally, you learn a lot about how to spot an air bronchogram, curly B lines, you know what's a consolidation, you know, things like, so it's not, I'm not going to teach you anything new in that, right? Whereas most of these things you haven't seen, and it's things that you just need to keep at the back of your mind, all right? So, yeah, we'll stop over there. I wish you guys a good day. Medicine. All right. And Vidisha, thanks for joining us, even though you came in the last 5 minutes, but I hope you'll watch the thing later. All right. Thanks. But if you have any question, now's the time. Otherwise, you can message me. All right.